Hello, this is Dr. Turkmani, and I would like to do a case-based discussion on Bowman Layer transplant as an onlay for the treatment of keratoconus and my opinion on whether this is the way forward. I have no financial interest to disclose relevant to this presentation. As a brief introduction, Bowman Layer transplant was initially developed as an inlay for the treatment of moderate to advanced keratoconus. The technique consisted in harvesting Bowman layer from a donor, and that Bowman layer graft would need to be inserted in an intrastromal pocket in the cornea of the patient. This proved to stop or delay progression in around 85% of the cases. However, the main risks were graft tears or thicker grafts than intended, with around a 30% rate of donor tissue wastage and a microperforation rate in patient host cornea of around 10%, usually requiring a PKP afterwards. The technique was recently modified and developed or performed as an onlay with preliminary results that were comparable to the technique as an inlay, and with a significant advantage, which is that there is no risk of microperforation, as you do not need to do a corneal pocket, and that it is eventually reversible. So here we go with the case. This is a 38-year-old lady with early keratoconus in the right eye and stage 4 keratoconus in the left eye, which is progressive and past the limits for treatment with standard cross-linking. As you can see, the topography K-mean was 69.4 diopters, K-max was 79.9 diopters, with a front corneal cylinder of 2.2 diopters and thickness at thinnest point of 335 microns. So a Bowman Layer Onlay transplant was performed on the 30th of June 2021, and one day post-operative, the graft was dislocated. So I took the patient to theater again for repositioning of the graft and suturing, this second time to make sure that the graft wouldn't move again, and the evolution post-operatively after this was very satisfactory. I removed the sutures 4 weeks after surgery with no adverse events, and there was very well integrated tissue with host epithelium having grown completely over the graft. In the right hand side of this slide you have a collage of pictures of the surgery. Basically the two pictures at the top is me harvesting the Bowman layer graft. The two pictures in the middle row is the Bowman layer roll in the left, and in the right that's patient's cornea after I scraped the epithelium. I want you to pay attention to that dimple to which I'm pointing at with the tip of the spear, because that is showing a stromal defect after I have removed the epithelium, which was masqueraded in the topography by epithelial remodeling, epithelial compensation. We'll need to go back into this topic later because that's one of the main interesting points of this case-based lecture. And the picture at the bottom is the appearance of the eye after I repositioned the dislocated graft and did a running suture to keep it in place. So before we continue discussing this case, we need to touch on some topics that apply to refractive surgery, but eventually they apply to any corneal surgery, and there are quite a number of links between these topics described in refractive surgery and this particular case. On the one hand, we know from the work of Cynthia Roberts, the cornea is not a piece of plastic. When you sever collagen fibers, they would retract as an elastic band and expand. So on the area where the corneal lamellae have been severed, there's going to be tissue expansion. We can see that when we create a flap for LASIK, for example, and a very significant example of this would be flap crunch syndrome. Basically, the corneal lamellae have been severed, have been cut. There is retraction of the flap in the equatorial diameter with expansion in the anterior to posterior diameter, and that is what can lead many times to microfolds in a LASIK flap. So if we think back on our case where the Bowman layer graft was dislodged, probably well soaked by the tear film of the patient for an overnight, so more than likely this would have caused swelling of the tissue with retraction in the equatorial diameter and expansion in the anterior to posterior diameter, leaving then a graft thicker than what would have normally been Bowman layer alone. We also need to talk about epithelial remodeling, epithelial compensation, and the first description on that was done by Alfred Vogt in 1921, just using the slit lamp, which is actually quite amazing to be able to describe such a process without any scans or OCTs available at the time. So Dr. Vogt said in 1921 that corneal stromal defects are filled in with surface epithelial cells. Of course, this has now expanded thanks to the work of Professor Reinstein to what we know today as the 4 rules of epithelial healing and the law of epithelial compensation. And what does the law of epithelial compensation say? This was described by Professor Reinstein, and it states that whenever there is irregular astigmatism, there is irregular epithelium. Or in other words, if an eye presents with irregular topography, then by definition, the epithelium has reached its maximum compensatory function. We have already mentioned that epithelial cells are capable for filling in depressions or gaps in the stroma, and we also know today that the epithelium thins over stromal peaks, that the epithelial remodeling or healing is proportional to stromal change, and that it also depends on the rate of change in curvature. For example, when the step or the gap in the stroma is quite abrupt, then the epithelium has greater capabilities for compensation and filling in the gap. That would be the example on the left hand side. Whereas if the rate of change in curvature is not that abrupt, as we could see, for example, in a small optical zone after a myopic ablation, then the capability for the epithelium to compensate for such a gap would be less. And if we go to the example on the right hand side, where the rate of change in curvature is even less, then the epithelium has the lowest capability for compensation. And in this slide you can see that the epithelium, with its capabilities for remodeling and smoothing corneal surface, they can masquerade many different underlying stromal surfaces. So basically the same corneal surface could be covering completely different underlying stromal surfaces, and therefore if we measure corneal power by using only surface topography, those measurements can be very inaccurate. So we go back to our case. Now the left hand side picture is 2 weeks after repositioning and suturing of the graft. The right hand side picture, it's 4 weeks after the repositioning of the graft with removal of the stitches. There is still a bit of ocular surface disease, a bit of punctate epithelial erosions. Epithelium is still recovering, but the tissue is well integrated and the epithelium has fully grown over the graft. And this is the topography 2 months after surgery. You can see that there has been a significant flattening of around 4 diopters in K mean, similar amount of flattening in K max, and very interestingly, a reduction in front corneal cylinder from 2.2 diopters to 0.2 diopters. This patient also reported that uncorrected vision seemed to her to be far less distorted than it was before surgery. Now let's stop for a moment in the postoperative OCT. We can see in the top there is a bandage contact lens, then there is a thin line which is the epithelium, then there is a thicker band which is the Bowman layer graft, which is thicker than expected, as we said, probably from tissue edema and tissue expansion, retraction in the equatorial diameter, expansion in the anterior to posterior diameter. And then we have patient's stroma, and I've highlighted there in the top right corner. The blue line is the epithelium, which you can see there that there does not seem to be that much of a remodeling or compensation. However, the red line is the dimple that we saw intraoperatively, and now it has been filled in by stromal tissue from the Bowman layer graft. So in this case, what we have now is a stromal defect that has been filled in with stromal tissue. Therefore, the epithelial remodeling over the cone is not that major, it's not that significant, and therefore we could conclude or think that the ocular surface topography now, it is far more accurate in reflecting the actual corneal power than if this was a case in which we had that stromal defect filled in with epithelium. We can compare here. On the left hand side again is the case of this lecture, and in the right hand side it's a comparable case of a Bowman layer transplant of mine in which I did Bowman layer transplant as an inlay. And you can see right top and right bottom is the same section. I've simply highlighted some interesting aspects in the bottom one. So the blue line would be the Bowman layer graft, the red line would be a similar dimple or stromal defect, and the space between the yellow and the red line in this case would be epithelial thickening, epithelial remodeling, filling in the stromal gap. So again, in this case of the right hand side, the surface topography would not be that accurate in reflecting the corneal power of that one case. More importantly, we know that the refractive index of the epithelium and that of the stroma are different. So we could expect that in the absence of correction with a rigid contact lens that can compensate somewhat for such kind of irregularities of the stroma, we could expect that the patient on the left hand side without correction could eventually have less visual symptoms or potentially less aberrations than that of the right hand side. But let's now also compare, instead of onlay with inlay, let's compare onlay with onlay. The picture in the right hand side is taken from Dr. Tapena's paper. She is a member of Professor Mellis's group in the Netherlands. Professor Mellis is the inventor of the technique as an inlay, and the paper reporting the results of Bowman layer transplant as an onlay for keratoconus is precisely from Dr. Dapen. I've put the reference below, and I've borrowed the picture from the paper, so you can see again that when the graft is form of Bowman layer alone, it looks like a very thin line in the OCT, with the epithelium growing over the graft. But again, you can see that in the apical area where there is that dimple, that stromal defect, in this case the compensation has been done again by epithelial remodeling rather than by stromal tissue, as it happened somewhat accidentally in my case because of the graft thickening up following the dislocation. Again, the results are comparable of inlay versus onlay, but eventually there could be a case, or one could make a case that it would be better to have stromal defects filled in with a stromal tissue and depend less on the epithelial remodeling. So a few interesting aspects to highlight here. When Bowman layer transplant is done as an inlay, the topographical changes are smoothened by epithelial remodeling. So as we've mentioned before, topography would not be particularly reliable to inform or to report what the actual corneal power is. Whereas by using Bowman layer graft as an onlay, the stromal irregularities can be compensated for with stromal tissue and therefore depend less on epithelial remodeling. We know that the refractive index of the epithelium and the stroma are different, so eventually we could argue that it's better to fill in stromal defects with stromal tissue rather than with epithelial tissue. And in this particular case of mine, that makes me wonder whether there could be an improved remodeling, let's say, or less dependence on epithelial remodeling if we use a tissue that is thicker than Bowman layer transplant alone, let's say in the form of a thin manual sulc, superficial anterior lamellar keratoplasty. So with what I've read about Bowman layer transplant inlay versus onlay, with my experience of Bowman layer transplant inlay versus onlay, I really think that onlay is the answer. If we make an analogy with endothelial keratoplasties, if for an endothelial disorder we do either DSEC or DMEC, which is replacing a healthy endothelial layer in its anatomical position with or without a thin stromal scaffold, then it would make all sense that for an anterior stromal disorder we should be performing either a Bowman layer transplant or Bowman layer graft with a bit of a stromal scaffold, which would be a thin sulc, as an onlay in its anatomical position. The other question I wonder is whether using slightly thicker tissue than Bowman layer alone would have improved optics. So in conclusion, we can say that the results of Bowman layer transplant as an onlay versus inlay are comparable. However, there are numerous advantages of this being used as an onlay. Number one, it's easier and safer than an inlay since there is no risk of host microperforation. Number two, as an onlay, it would be a selective and anatomical replacement of the disease layers. Number 3, as and only there's a potential for filling in stromal gaps with stromal tissue. And number 4, in doing so, there would be possibly less epithelial remodeling required with more accurate reading of the corneal power by the topographer. I've put the references to the relevant papers that relate to this talk in this slide. Before I finish, I would like to thank Professor Dan Reinstein and Professor Jorge Alio for reviewing the content of this lecture. And I hope you enjoyed this presentation. Thank you very much for your attention.